Hello, 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 everyone. Welcome back to day 8 of 12 days of ICD-10-PCS coding. Today, we are focusing on group number 5, which has 4 root operations. First, we have occlusion, which is completely closing an orifice or a lumen of a tubular body part. Then we have the opposite of occlusion, which is restriction. And if occlusion is completely closing, restriction is partially closing an orifice or the lumen of a tubular body part. Then we have dilation. Dilation is expanding an orifice or the lumen of a tubular body part. Last and certainly not least, we have bypass, which is altering the route of passage of the contents of a tubular body part. If you haven't figured it out by now, these 4 root operations alter the diameter or the route of what? A tubular body part. So, we are going to get started with our first scenario. Our first patient underwent an exploratory laparotomy after presentation with severe urinary hemorrhage. During the procedure, it was discovered that the patient had an extensive adenocarcinoma of the left kidney with metastasis to the left lower lobe of the lung, great vessels, and lateral diaphragm. The tumor could not be removed. Therefore, the ureter was surgically ligated to prevent further urinary hemorrhage. So, what did we do here? They ligated it. So, they occluded the area, and the root operation is occlusion. So, we will go right to our coding manual, electronic version, and go to the root operation of occlusion. Our body part is the ureter. And we're almost there. Well, somewhere, I need my glasses on. All right, there we go. It was on the left side. So that's table 0TL with the body part of 7 for left ureter. The first thing that you should notice, ureter is in the first row and the second row. As a reminder, per the rules, we have to build our code going across. All right, so after that, we need to determine our approach, which was open. So we're going to stay in that first row. No device, no qualifier. Final code 0TL70ZZ. All right, I'm going to take that back to the top and go to our next scenario. All right, remember I said that over the weekend our sessions would be a little longer? Here we go. Patient had a PTCA with insertion of a cipher drug-eluting stent of the proximal mid left anterior descending coronary artery. Prepped and draped in a sterile fashion, the right femoral artery was accessed, and an XXB 3.56 French guide catheter and a BMW wire were used. Immediately after, they found the origin of the left diagonal branch. There was about 80% eccentric LAD disease. Mid and distal LAD appeared unremarkable. A cipher stent, the stent that they told us about, was deployed. Let me just pause here for a second and just tell you something. When you're coding real world ICD-10 PCS coding, you cannot code from the header of the report. You must read the entire report. Let's continue. A cipher stent was deployed, covering the entire moderately diseased proximal site and post-dilated with 3.0 by 15 mm power cell balloon up to 15 atmospheres. This resulted in a fully deployed stent, no evidence for dissection, thrombosis, or distal embolization. Guide wire and catheters were removed. and the left femoral arterial sheath was removed, and the patient tolerated the procedure well. So what did they do here? They put that balloon in to smack that plaque up against the wall. That balloon keeps the area open so that the blood can fly through. So root operation is dilation, and we know dilation is expanding an orifice or the lumen of a tubular body part. So we're going to go on over to dilation. And dilation of what? It was an artery, and it was one site of the artery. So let's see. Oh, what artery was it? Coronary artery, right? Coronary artery, because they talked about the LAD and all that stuff. So it was the coronary artery. It was one coronary artery. Takes us to table 027. And from there, what is the approach? The approach was percutaneous. They did deploy a stent. It's an intraluminal stent. It was one stent. And then there was no bifurcation. They didn't split it into two. So the final code is 027034Z. All right, back to the top and back to our next scenario. So our next patient had a cabbage times 4. So 4 sites were bypassed. In the top of the report, they talk about how the saphenous vein graft to the obtuse marginal, diagonal artery, and posterior descending artery. Lima, the left internal mammary artery, to the LAD, the left anterior descending artery, and then coronary artery pulmonary bypass. We will code coronary artery pulmonary bypass. It is not in the medical and surgical section, but we're going to code it. So as I mentioned before, very important for you to know about the procedure. And that's important because you can't just read the report and not understand what you are reading. Okay, that's so very, very, very important. Okay. So from there, we're going to go to the root operation of bypass, because that's what the patient was having. Okay, so B, and you know what? Let me go back, because I'm like, bypass begins with a BY, so I want to go backwards. All right. Oh, look, we just ran into the code for the coronary pulmonary bypass. So write this down. 5A1221Z. I'm going to click on it because you know you cannot code from the index only. So 5A1221Z. 1 for the output, and then Z, no qualifier. All right, now back to the top, and let's get the actual bypass that we were looking for. But that was good. We ran into that, right? All right, so what was bypass? Okay, in the scenario, and I haven't pulled the code book up yet because I wanted to give you all a chance to actually go through the scenario again. So let me just, for those that were like, what are you talking about that bypass? See, it's at the last word of bypass. All right, so when we get to here, they want to know what was bypassed. Was it a vein or was it an artery? And if you saw on the screen, I kept it up long enough. We are talking about the coronary arteries. So per guidelines, coronary arteries or bypass grafts are coded based upon the actual sites, number of arteries treated, And in our case, they said it was a total of 4, which it was. But in one of the arteries, they did a device, or in 3 of the, three of the arteries, they did a device. How do I know? Let me go back to the scenario. So they use the Lima. The left internal mammary artery was subsequently brought through a subthalamic tunnel and placed into side with the left anterior descending artery. And you know what I realized? I didn't even read this whole scenario. So I'm glad I left it up there while I was busy going on in the book. It's a Saturday morning. I've had lots of caffeine so far. All right. So now where was I at? So 3 sites where they used the device, which they used the patient's own situation. So let me just go back a little bit further. The Lima was dissected as a pedicle using electrocautery and small hemoclips at the same time that the greater saphenous vein was harvested endoscopically from the left lower extremity. There is a guideline that talks about when you use a patient's own vessel for part of the bypass, you can code that separately. It's coded to the root operation of excision. If you're like, I don't know what you're talking about, that means you need to read those guidelines because it is covered under there. All right, so back to this code book. So it's coronary artery. We had 4 vessels total, but 3 of them had a device. So we need to code that separately than the one that did not have the device. So in any case, we're going to go to table 021. So let me get over there now. And the first code, the 3 sites. So 021, 3 sites, 3 or more arteries. And you're like, wait a minute. We got that repeated. The 3 is repeated multiple times. First thing you want to look at is the approach. Our approach was open, so you can get rid of the rest of these, right? Okay. Our approach was open. Now, the next thing you need to determine what was used for the device. Well, in our particular case, it was the patient's own vessel. Autologous. It was an autologous vein. So that's a 9. And then the 7th character, it went to the aorta. And again, there are some rules for how bypasses are coded for coronary versus non-coronary vessels. So the final code here, 0212009W. We need to code that single vessel where no device was used. That's 021. 4th character of 0 for 1 artery, 1 site, and then 0 for open. And then there's no device. And the 7th character, internal mammary artery. I know that was pretty challenging from a rigor perspective. What I can say to you is I recommend, and I don't work for AHEMA, but AHEMA's clinical coding workout book has some really good exercises that can give you some more practice with this area. All right, on to, oh, wait a minute. I got to do one more thing. We got to code that excision. So we're going to go to the index. And we're going to go to excision. I'm going to go backwards just so I can get there faster. And it was the greater saphenous vein. Excuse me. It was the greater saphenous vein that was excised. All right. So saphenous, left, 0, 6. No, that doesn't seem right. Let me just go back up for a second. Oh, first of all, that's extraction. So that's part of the problem. Okay, what did we just learn? We need to be at the beginning of the word and make sure you're at the right word. Because I was like, that doesn't look right. So it was a good thing I was paying attention. And see how they could trick you on the CCS exam with a situation like that? All right, so greater saphenous vein. Oh, it's extirpation. Okay. So you know what that means. I am not paying attention. Actually, what I was trying to do was show you how you could get caught up on the day of the test. Now, on the day of the test, on the day of your CCS exam, you're not going to be doing main term, subterm, all that business. You are going to go right to the table and look at the numbers because you don't have time to do main term, subterm. It's just not enough time for that. The answers are there. They're not asking you to code per se because the answers are there. Excision. Look, excision. All right. So it was the vein. It was the greater saphenous vein. 06B. B is for excision. All right. 06B, and it was the left. So that's Q. Now, how was this done? And I know some of you are like, I don't remember. It was so long ago. We've been going back and forward. In the scenario, it says, oh, that's the wrong one. Let me go back. In the scenario, it said the greater saphenous vein was harvested endoscopically. All right, so we know that that is a number 4 for percutaneous endoscopic, no device, and no qualifier. So 4 codes, 02120 9W, 02100 Z9, 5A1221Z, and then 06BQ4Z. All right. I think I'm too pumped up for the weekend. And our last case in group number 5, this patient had cervical incompetence and they did a cervical cerclage. So what is a cerclage? You're going to be restricting that area so that the mother can carry the baby to term. So that being said, under general anesthesia, the abdomen was prepped and draped in a regular fashion. They did a transverse suprapubic incision. The vesicoperitoneum overlying the uterine segment, the lower uterine segment, was divided transversely. The uterine vessels were displaced laterally, opening the paracervical connective tissue space. The needle was passed anterior posteriorly through the paracervical vessels immediately adjacent to the cervical area at the level of the cervical isthmic junction, superior to the medial insertions of the uterosacral ligaments. Care being taken to retract the uterine vessels laterally and guide the needle tip with fingers beyond the broad ligament before being pulled through completely, and the bandwidth of the tape was verified as being flush with the anterior cervical isthmic tissues. The knot was tied in the posterior. Bam. What did they do? They did a restriction. And again, I just want to reiterate, this is only 12 days with about 12 minutes. Today, we're going to be a little bit over 20 minutes, but you got to get a book to practice. If you want to be an inpatient coder, you need to practice, read. And one of my famous statements, you should be learning faster than you are growing. And sorry, guys, because I'm just scrolling away. Repair. I should have went backwards. I'm getting close. This is kind of why I like flipping through the book, because scrolling through this is kind of a lot. But nonetheless, this is what we have. It's free on the internet. So I say if you are in the practice phase, go ahead and use it, right? Because it allows you to get the things done that you're trying to do, which is practice. Definitely should have went backwards. All right. Restriction of what? Well, it wasn't a aorta or artery. It was actually restriction of the cervix. So mom can carry the baby to term. Table 0UV with a 4th character of C for cervix. As usual, we notice that the C is listed in 2 areas. And so what we want to do is think about what was our approach. Well, our approach was open. They used an extraluminal device. It was on the outside, and there was no qualifier, making our final code 0UVC0CZ. Well, guys, we have made it to the end of another group of 12 days of ICD-10 PCS coding. Sunday will be a lot because we have root operations that always involve a device. And there are 6 root operations that always involve a device. And so tomorrow, I will cover those. So these are the 6 that you can look forward to. I will see you on Sunday.